All right, let's talk about pathology. So, what are the common brain lesions that we have? So, the first thing is the prefrontal cortex. Area of the lesion is the prefrontal cortex. So, I have a picture here so you can really see what we're looking at. So, prefrontal cortex right here, right? So, let's talk about this. If you have a lesion here, what's going to happen is you will get something called frontal lobe syndrome. That is basically you have a disinhibition, hyperphagia, impulsivity, loss of empathy, and impaired executive functions, akinetic mutism, and it is also seen in frontotemporal dementia. So if you knock this out, if you have a lesion in the frontal lobe cortex, prefrontal cortex, you're going to get frontal lobe. So hold the frontal lobe, whatever the function of frontal lobes are, which we talk about in physiology, they will be gone. And the example that we made over there, just writing the same example here, is if you ask the patient what's the difference between a watch and a ruler or a scale, they're going to say it's the same because both of them are showing numbers. Both have numbers. They will not be able to differentiate, okay, one is watch for time and the other is for purposes of measuring. They will not be able to do that. That's frontal lobe syndrome. I mean, that means the frontal lobe is out. And also the working memory is going to be out. There's going to be disinhibition, hyperphagia, impulsivity, loss of empathy, executive functions are out, personality, everything we talked about as a normal thing will be out in the patient with a prefrontal cortex lesion. Let's look at the other one. Now we have the frontal eye fields. Let's locate the frontal eye fields here. So frontal eye fields are going to be, where are they? Here, right there. Okay, let's just make a arrow there. So frontal eye fields, I look towards the brain lesion. Important. Away from the site of hemiplegia seen in the MCA stroke. So MCA stroke will mess up the frontal eye field and the eyes will look towards brain lesion. Whichever side is affected, it will look over there. Then you have this paramedian pontine reticular formation, PPRF. That is, I would look away. Now here's the difference. So if you look here, if you have a frontal eye field, which is in the frontal lobe, if you have a problem there, the eyes will look towards lesion. While if you have a problem in the PPRF, the eyes will look away from the brain lesion towards the hemiplegia. Okay. Then let's talk about dominant and non-dominant parietal cortex. So the dominant parietal cortex, if you knock out the dominant, if there's a lesion in the dominant side of the parietal cortex, then you get something called Gertzmann syndrome, which is agraphia, acalculia, finger agnosia, left-right dissociation. So what is agraphia? Agraphia is inability to write. They will not be able to write. What is acalculia? As you calculate, right? So can't calculate. Okay. Finger agnosia. They will not be able to identify their own fingers on the hands. Okay. And then you have the left to right disorientation, which is basically they will not be able to tell the orientation of them. One more thing added to it is going to be alexia. Alexia is they will not be able to read, so inability to read. So agraphia, acalculia, finger agnosia, left to right disorientation, and alexia. What if the lesion is on the non-dominant parietal cortex? You will get something called hemispatial neglect syndrome. Well, hemispatial neglect syndrome is agnosia of the contralateral side of the world. So what it is the person will not be aware of his own one side of the body. So not aware, patient will not be aware of one side of the body. So that's called hemispatial neglect syndrome, that they will not be able to tell, and this is non-dominant. Okay. Then looking at the next one, we have the basal ganglia. So what is the basal ganglia? Basal ganglia, if you have a lesion of basal ganglia, you will see tremors at rest. Again, at rest. You have chorea ethetosis. Chorea ethetosis, seen in Parkinson's disease and Huntington disease. Okay, and both of them you have. So what is chorea and what is ethetosis? Let's talk about that quickly. So chorea is about you have a fast random involuntary movement versus ethetosis. So let's just keep it both together. Ethetosis is all about you have slow random involuntary movements, slow or ethetosis. But when these movements become fast, they're called chorea. They are the fast random involuntary that it's not in your control, you're just doing it. Okay, and that is seen with the Parkinsonism and Huntington disease. Okay, now the next one is subthalamic nuclei. Subthalamic nuclei, STN, will give, if there is a lesion of the STN, you will have a contralateral hemibelismus. So you will see a contralateral hemibelismus. Okay. The next thing we have here is going to be, and the way you can remember this thing, hemibelismus, and we'll talk about that in, again, pathology, is like a patient will be doing like jerky dancing movements. So you could really think about STN as Michael Jackson dance. Very dancey movements, and you'd be like, what are they doing? Moonwalking sort of a thing. And you'd be like, what is it? So that's hemibelismus. And we'll talk about that in future. It's going to come in pathology. But then you have this mammillary bodies. Mammillary bodies, let's just erase some extra stuff here. Mammillary bodies, if you have a bilateral lesion of the mammillary bodies, it's called Wernicke-Korsakoff syndrome. And why a very high yield? Why is it thiamine deficiency? And there are so many risk factors to the thiamine deficiency. Chronic alcoholism is one of that. Okay, so Wernicke-Korsakoff syndrome, bilateral mammillary bodies lesion. Okay, and that's what we have there. But here, what is Wernicke-Korsakoff syndrome? We will touch on that again. But here, just to touch a little bit here, Wernicke-Korsakoff syndrome is basically acute encephalopathy with chronic neurological problems. So Wernicke-Korsakoff acute encephalopathy with chronic neurological symptoms. For example, what chronic neurological symptoms are we talking about? Like confusion, ataxia, nystagmus, ophthalmoplegia. So all of that are the sign symptoms of this chronic Wernicke-Korsakoff syndrome. Okay, it is often reversible again. See, it is thiamine deficiency, so it is often reversible with thiamine supplementation. But if Wernicke's, okay, let's just write here because that's important. Wernicke's is reversible if you give thiamine. But if they develop a Korsakoff, which is going to be a problem with amnesia, with memory, this is usually permanent. So even if you give thiamine, you might not be able to fix the memory problem. And we will talk about, I think this is more in biochem with the vitamins, so we'll talk about that. But here, then we have the amygdala. Amygdala, if you have a bilateral lesion of the amygdala, you call Kluver-Bucy syndrome, which is, again, disinhibition. We talked about disinhibition up top, which is, again, hyperphagia, hypersexuality, hyperorality. It is also seen with, as we see, 1 encephalitis. Herpes simplex virus 1 encephalitis. Okay, so with this, what's going to happen is these patients, so hyperorality, for example, so these patients they would like to examine everything with mouth. Examine everything with mouth. Okay, and with hyperphagia, they will have a weight gain, and with hypersexuality also being there. Okay, and that's with the bilateral amygdala lesion. All right, the next we have the hippocampus. Hippocampus is about lesion on the bilateral side will give you anterograde amnesia. For example, what is that? That's meaning no new memory formation. It's seen in Alzheimer's disease. So hippocampus is out, seen in Alzheimer's disease. Okay, Then you have this dorsal midbrain. If you have a lesion of the dorsum of the midbrain, it's called Perinaud syndrome, which is often due to pineal gland tumors. So if you just recall, you have this pineal glands, right? And if there's enlargement of these pineal glands, you're going to push on the dorsum of the midbrain. For example, if you have a pineloma, you're going to push on the dorsal midbrain. When you push on it, there's going to be lesion here, and it's going to lead to Perinaud syndrome. Okay. And let's talk about, I don't know if they have mentioned it here or not, but let's just quickly look at this. What is Perinaud syndrome? That is basically when you have limitation of the upward gaze with a downward gaze preference. Why? Because you have a vertical gaze palsy. You have a vertical gaze palsy. And what else you might have? Pupillary right near dissociation. That's another thing. Lid retraction and convergence retraction nystagmus. So people, what do I mean by? So a couple of features. I think we'll talk about it, but if not, we'll come back to it in somewhere. I think I did talk about in anatomy about this as well. So, but the important point here is, the very high yield point is that you have something called pineal gland mass, for example, pineloma, which is going to, if you have pineloma, which would compress the dorsal midbrain, and causing Perinaud syndrome. With the Perinaud syndrome being there, all you have is eye problems, and what there will be, you will see an upward gaze with the limitation to the upward gaze with the downward gaze preference. Let me just write that one. So you will not be able to have an upward movement. So limit on the upward and a downward gaze preference. And we will talk about Perinaud syndrome for sure. Then we have this reticular activating system. Reticular activating system, if there is a lesion, then there is a reduced levels of arousal and wakefulness, So very important. So it is, if you have a lesion on this area, which is your reticular activating system, it will lead to reduced arousal, leading to coma. Then you have the MLF, medial longitudinal fasciculus. With medial longitudinal fasciculus, here what we're going to have is, it's called internuclear ophthalmoplegia. What is internuclear ophthalmoplegia? It is impaired adduction of the ipsilateral eye and the nystagmus of the contralateral eye with abduction. Again, what do we talk about? We could not adduct, meaning joining together like medially, the ipsilateral eye, and there's going to be nystagmus of the contralateral eye when you try to go look on the lateral side, which is abduction. And we will talk about this in eye for sure. It is seen as MS. It is seen in MS, multiple sclerosis. Okay. Then you have cerebral hemispheres. Lesion in the cerebral hemispheres will give you intention tremor. My bad, not cerebellar hemispheres. Okay, intention tremor, limb ataxia. If you recall, we talked about hemispheres on the sides and vermis being the middle part of this whole cerebellum, right? So right now we just talk about the hemispheres, left and right hemispheres. And then we will talk about vermis here. So if you just have a mess up, if you have a lesion of the hemispheres, you will cause intentional tremor, limb ataxia, loss of balance. It is all due to damage to the cerebellum, which causes ipsilateral deficits, fall towards the site of lesion. Cerebellar hemispheres are laterally located, so affects the lateral limbs. See, they are, let me change color here. They are laterally located, so they will affect the lateral limbs. Okay, as compare this with the vermis. Vermis will give you, because it's in the midline, it will give you truncal ataxia, which is a wide-based drunken sailor gait. Okay, nystagmus, dysarthria, degeneration associated with chronic alcohol overuse, high yield, chronic alcohol overuse. Wormus is centrally located, so it affects the central body. It will affect the central body. So that's what you have with cerebellar lesions. Now let's look at the bottom here. Here we have the abnormal motor posturing. We have decorticate and decerebrate posturing. So decorticate is the flexors posturing and decerebrate extensors posturing. Let's take a look at each one of them. Okay, in the decorticate, where's the lesion? It is the above the red nucleus, above red nucleus, and it is in the decerebrate. It is between the red nucleus and the vestibular nuclei on the brain stem. So the way you're going to remember this thing is at site of lesion. Let's actually look at the whole thing, and we will talk about how we can remember this. Overactive tracts are going to be rubrospinal and vestibulospinal tracts. Presentation is upper limb flexion, lower limb extension. So if you look at the lower limb, it's extended. If you look at the upper limb, it is flexed. Flexion is when you have two areas of the body close together, it's called flexion. And when the two areas of the body, they are far apart, that's called extension. Okay, so flexion of the upper limb versus extension of the lower limb. And on the other hand, the cerebrate is upper and lower limb, both of them are extended, right? With corticate, your hands are near the core, and this is the mnemonic now. What is the mnemonic? Your hands are near the core. Core mean the heart, right? So, and this guy, the other thing is decerebrate, which has the worst prognosis. So if the way you're going to think about it is decorticate, meaning core. So when the hands are near the core, it's going to be decorticate. And you're going to think about flexions. It's a flexor posturing. Versus decerebrate is the hands are not in the core, so that means they're just extended. So everything is extended. The upper limb and the lower limb, all of them are extended. Okay, so that is all for the abnormal motor posturing. And that is all. One more thing, lesion. One important thing is, where's the lesion? Red nucleus is the key point here. Red nucleus. If anything is above red nucleus, it says decorticate. Anything at the level of red nucleus or below, so at or between red nucleus, meaning at this site, if you have a problem, you're going to have a extensor posturing. Okay, and the way you can just think about it as, just remember this, you talked about decorticate first, so it is going to be above the red nucleus. And then you talked about cerebrate, so that's going to be at or between the red nucleus. And the other thing that is important here is just about flexion, extension, and just extension. And with the worst prognosis, decerebrate being the worst prognosis. Okay, so let's just review this and move on to the next. We talked about a couple features here. Prefrontal cortex, meaning frontal lobe is out, you will get frontal lobe syndrome. Frontal eye fields are out, high yield, the eyes will look toward the brain lesion. If the PPRF, and we will talk about that in ophthalmology, the eyes will look away from the lesion. Dominant lobe is out, Gertzmann syndrome. Non-dominant out is hemispatial neglect syndrome. Basal ganglia, you already know basal ganglia. Parkinson, Huntington. Subthalamic nuclei, hemiballismus. What is hemiballismus? Michael Jackson dance. Okay. Then we have mammillary bodies. Mammillary bodies, bilaterally they are out. Wernicke-Korsakoff syndrome, thiamine deficiency. Amygdala, Kluver-Bucy syndrome, hyperphagia, hypersexuality, hyperorality, also associated with HSV1 encephalitis. Hippocampus, interrogate amnesia. Dorsal midbrain due to pineloma with Perinaut syndrome. RAS, wakefulness, arousal. MLF, medial longitudinal fasciculus, all about internuclear ophthalmoplegia, MS. And for sure, this is high yield, and we'll talk about that. Cerebral hemispheres, it's all about in the hemispheres out, hemispheres on the lateral side, you will have a lateral limb ataxia, intentional tremors, versus the cerebrovermis, which is in the center, so centrally affecting central of the body. For example, the gait is central, right? Yeah, and also nystagmus and dysarthria. And the corticate, we talked about that. So that's all for this one. Let's move on to the next. All right, let's talk about ischemic brain disease or stroke. This is irreversible neuronal injury, which begins after 5 minutes of hypoxia. Most vulnerable are going to be your hippocampus, CA1 region, and neocortex, cerebellar Purkinje cells, watershed areas. We did talk about all of these things in the watershed zone areas, but here again, a repetition of all. It's going to be hippocampus, neocortex, Purkinje cells, and also the watershed areas. So the mnemonic here is very good. Vulnerable hippos need pure water. Vulnerable meaning they're vulnerable. Hippos mean hippocampus, need neocortex. Pure mean Purkinje cells of the cerebellum, and water means all the watershed areas. Okay, now stroke imaging are going to be high yield, non-contrast CT, very high yield. You have to do a non-contrast CT scan, non-contrast, okay, to exclude a hemorrhage before TPA can be given. Well, CT would detect ischemic changes in 6 to 24 hours, and diffuse weighted MRI can detect changes within 3 to 30 minutes. Okay, so that is going to be a yield point. Okay, what else you might have? So one thing, if you just think about it, 5 minutes, it's not a big deal, right? 5 minutes is like, it's a snap. Excuse me. Right? So if you have, the question might come up as, if you already know that there's going to be irreversible injury within 5 minutes, but what if the ischemia was less than 5 minutes? What's going to happen then? Well, if you have a ischemia less than 5 minutes, that is going to give you cellular swelling. Cellular swelling. Cellular swelling enlarged, for example, enlarged neurons. Okay, and that is important. And with after 5 minutes, it's just hypoxia. You will get, from most vulnerable, everything is going to go into, there's going to be a lesion on these things. Okay, what else we might see there? Let's look at the time since the ischemic events. So here we have histologic features and the time frame, right? So in 1 day, this is the 1 day, right? 12 to 24 hours. What we'll see is we will see eosinophilic cytoplasm plus pycnotic. Pycnotic just means shrunken, okay? Shrunken nuclei, which are known as red neurons. Now, important vocabulary here. Red neuron. When you shrunken the nuclei, you call it a red neuron. Okay, but also, which they haven't mentioned, is you will also see loss of Nissl substance. Let me just where do I do this? Okay, let's just do it here. Loss of Nissl substance. And if you want to look how, if you want to know more on this loss of Nissl substance or what is this, is again based on neuroanatomy lecture back in the neurons. So loss of Nissl substance. Nissl substance will be seen. What else? Hypnotic will be seen, yeah. And then in after this, so after your 1 day, so this was 1 day. So after the 1 day, so 1 to 2 days, or actually call it 3 because 72 hours there. So 1 to 3 days, what you're going to have is you will start necrosis plus neutrophils. High yield is neutrophils. Neutrophils would infiltrate. Okay. And within 3 to 5 days, the macrophages, which are known as microglial cells, they will infiltrate. And when they infiltrate, and they will start what? Phagocytosis, right? So microglia will start phagocytosis, begins at this point, right? And this fragments of myelin, the debris accumulation within the cytoplasm of this microglial cells, and they will make as foamy cells. Foamy cells. Okay. Um, then you have after 5 days, you're going into weeks now. So 1 to 2 weeks. So you have here you have reactive gliosis, which is done through astrocyte proliferation, okay, and vascular proliferation around that necrotic area, okay. And also, one more thing you will have is there's going to be digestion of the brain tissue and removal of the brain and necrotic tissue by lysosomal hydrolytic enzyme released by inflammatory cells and damaged neurons. So this is a very important point. We did talk about a neuroanatomy, which is these damaged neurons. For example, even the myelin, even the Schwann cells. What they will do is they will release the cytokines, and that will get more and more inflammation there, leading to release of lysosomal enzymes, which will degrade more and more tissue, and it will be picked up by the macrophages to clear up the mess. After 2 weeks, let's just erase this. After 2 weeks, important high yield, there's going to be a glial scar formation, right? And that is again done through which process? The reactive gliosis, which was done through astrocyte proliferation. So they proliferate and make a scar. Astrocytes, think about astrocytes as the fibroblasts. Fibroblasts did do the same thing, right? But astrocytes are in the brain, and fibroblasts are all over the body. Okay. So here, what we will see is one more thing is going to be astrocytic process, glytic scar. Remember these wordings for gliosis, glial scar, astrocytes, astrocytes, astrocytes. Okay. And if you recall your general pathology, there was a liquefactive necrosis within the brain, right? So where was that taking place? So by 1 week here, after the macrophages are eating every single thing here, it's going to go from 1 week to 1 month, something called liquefactive necrosis. Liquefactive necrosis, which when you have the liquefactive necrosis, so let me just write this again down, 1 week to 1 month, liquefactive necrosis. So greater than 1 month, what's going to happen is that liquefactive necrosis area, there's going to be formation of cystic cavities, cystic cavity formation, which will be surrounded by a wall composed of dense fibers, which are found by the astrocytic processes. So let me just write this down. So high yield is the cystic cavities will form with the wall surrounded by these astrocytes. So astrocytes will be there, astrocyte processes will be there, but in between them you have cystic cavity. And guess what? Who's going to fill the cystic cavity later on after 1 month? CSF. Okay, that is there. What else you might see? Okay, going back here at the very start of it, we said even before this time, let me just do this. Before even the 12 hours, we said we would do a non-contrast CT, and ischemic changes will be seen by 6 to 24 hours. So right about at 6 hours, let's say 6 hours, right? So 6 hours afterwards, what we will see is, so recalling sort of normal radiology here. So you in the blood would appear on CT, the blood appears white. Okay, and so what you will see is if you have an so they will say hypoattenuated areas, hypoattenuated, which basically means it's dark looking. So hypoattenuated brain tissue with loss of gray white matter differentiation in the affected region. Okay, again, one more thing. Just take a look. CT will show blood as white, and the ischemia would look like hypoattenuated area, which is dark. blood looks white. Okay, and that is also there. Um, Other than that, let's just talk about some features of it. So with ischemic stroke disease, stroke, what's going to happen? You have a sudden onset of neurological deficits. Okay, uh, why? Because of death of the brain tissue. Risk factors to ischemic brain disease are going to be your hypertension, diabetes, hyperlipidemia, smoking, uh, everything same as almost same as cardiovascular uh, risk factors. Okay, what else we might see? So let's just actually that's about it. So let's just quickly go through these and move on to the next thing, which is actual ischemic stroke. So here we talked about how ischemic brain disease stroke will affect after 5 minutes of ischemia. There's going to be irreversible damage. If it was less than 5 minutes, it would give you reversible damage, which will be only seen as a cellular swelling, which is enlarged neurons. Uh, Variable hippos need pure water. That's a mnemonic. Got to do non-contrast CT to rule out hemorrhage before starting TPA. CT would detect changes in 6 to 24 hours, but MRI, diffusion weighted MRI, can detect about 30 minutes. Okay. Some changes are going to be eosinophilic, which is basically pink cytoplasm with pycnosis, meaning shrunken nuclei. So shrunken nuclei with pink cytoplasm, loss of Nissl substance will be seen here, known as red neuron here, with 1 to 3 day neutrophil, 3 to 5 day macrophages, 1 to 2 weeks reactive gliosis, astrocytes proliferation, after 2 week glial scar, and on macrophage will cause liquefactive necrosis. That liquefactive necrosis will form cystic cavities. Those are going to be surrounded by these astrocytes, processes, which will form the scar. Then next we have this ischemic stroke itself. What is ischemic stroke? Let's erase a little bit of the extra stuff here. Okay, ischemic stroke. Ischemic stroke is ischemia causing infarction, right, leading to liquefactive necrosis. Simple, right? There are 3 types to ischemic stroke. 3 types. We have the thrombotic, meaning, let me just do this. Thrombotic means you have a thrombus formation of the whole vessel, and there's a breakage of anything, and it causes thrombus formation of the vessel. So you occlude the whole vessel. So you do clot forming directly at the site of infarction, commonly at the MCA, usually over ruptured atherosclerotic plaque. So you have atherosclerotic plaque. There's a rupture. When you rupture, there's going to be formation of full clot formation that would block the whole artery, right? Most commonly MCA, and that will give you thrombotic stroke. Then you have the embolic stroke. For example, something comes from the left heart side, and it, for example, in case of AFib, atrial fibrillation, or if there is a PFO, patent foramen whale, which is to a lesser case, AFib to a more likely case, that can cause an emboli to come into the left circulation and go into all over the body. Example, going to the brain. This emboli can reach here, and let's read, due to an embolus from another part of the body, can affect multiple vascular territories. Example, look at the examples. AFib, carotid artery stenosis, DVT with patent foramen whales. DVT, remember the concept here, DVT would not give you left sided embolism, right? Because if, let's just think about it, you have a vein deviant thrombosis, that emboli is going to come, but it's going to lie somewhere in the lungs. It will never be able to cross and go all the way to the left side unless or until there is a opening between your right heart and left heart. So that opening is the PFO, patent foramen whale. Okay, and that's what we have there, which is known as paradoxical embolism. Okay, high yield. Then the next thing, you have infective endocarditis. Infective valves have these vegetation which will throw these emboli and which will go into the left heart circulation. The next is we have hypoxic stroke. Then hypoxia due to systemic hypoperfusion. Again, Hypoxia due to hypoperfusion or hypoxemia, commonly during the cardiovascular surgeries, tend to affect the watershed areas. Again, if you have a hypoxia, hypovolemia, hypoxemia, hypoperfusion, commonly in big surgeries like cardiovascular surgeries, then the most they will tend to affect the watershed areas. On top of watershed areas, you will also think about the full mnemonic, which was uh, vulnerable hippos need pure water, all of that. Okay. Now let's look at the treatment options what we have for ischemic stroke. TPA, if given within there's a window with that window is 3 to 4.5 hours of onset and no hemorrhage risk of hemorrhage is there. So again, what are they trying to say? You give TPA without any contraindication to the patient, okay? And or thrombectomy, which is if large occlusion. If you have a large occlusion, you got to do thrombectomy, not TPA. Reduce risk with medical therapy, for example, aspirin. You can only reduce the risk with aspirin, clopidogrel, optimum control of blood pressure, blood sugars. These are all the risk factors, right? So you got to control blood pressure, blood sugar, lipid levels, smoke cessation, and treat conditions that increase the risk. For example, AFib, carotid artery stenosis. Okay. What else we might see here? Um, then we have the next topic here would be your TIA, transient ischemic attack. TIA is brief, as the name suggests, transient, brief, reversible episodes of focal neurological deficits. There's a focal deficit without acute infarction, meaning there is no acute infarction. So you will not see a thing on MRI. MRI is normal, negative MRI, with the majority resolving when? Less than 15 minutes. So they have a focal neurological deficit, and you're like, what's going on? But that fixes within 15 minutes. Okay, but question is why does it happen? Well, when you have ischemia, for example, embolus, small vessel stenosis, may present with hemorrhages fugax, which is a transient visual loss. They have a transient visual loss. Imagine that. And that comes back after 15 minutes. Wow. Due to retinal artery emboli from carotid artery disease. Okay. Uh, so this is what we have. Again, why does this happen? Because there's a transient ischemia, but that wasn't enough to cause infarction. There's a transient loss of blood supply to the locally, only to a single or somewhere, not the whole global brain, but only to some specific area. But that wasn't enough to cause it infarction. So TIA, high yield TIA, is going to present with some focal neurological deficit, which would come back. Those deficits, meaning those the neurological dysfunction, will become normal after about 15 minutes. So those deficits are just for 15 minutes. Okay. What else you might see? I mean, high yield brain imaging is very normal. You take a look at brain imaging, is everything is normal. And also it is localized to where? Focal, single site, single region of the brain. And sign and symptom would resolve without any intervention. You don't have to do anything. No intervention needed. And patients with TIA, what high yield point is with the patients who already have TIA, they are increased risk for future strokes. So there is a risk they're going to get a full blown stroke, which is called future strokes, right? So you have to do a prevention on these, which is known as secondary prevention. And secondary prevention is you're going to start them on medical therapy and also change the lifestyle. Okay, try to decrease anything that would lead into it. High yield is hemorrhages fugax. It is a transient visual loss with the TIA, transient visual loss. Again, why did this happen? Because of retinal artery emboli from the carotid artery disease. So you already have a predisposing factor, which is this carotid artery disease. With the carotid artery disease, an emboli shoots off, goes into the retinal artery, and causes hemorrhages, or I don't know how you call it, but hemorrhages fugax, right? and that's there with the transient visual loss. And TIA is less than 24 hours. High yield point is, again, TIA would be less than 24 hours, typically in less than 24 hours. Okay, then you have this the next topic, which is cerebral edema. Cerebral edema. This is fluid. It's the same thing. Excuse me. Fluid accumulation in the brain parenchyma. Edema is the fluid which accumulates in the parenchyma. That increases when you put the fluid in there. There's a very compact space. It's going to increase the ICP for sure. Types are either you have a cytogenic edema or you have vasogenic edema. So cytogenic edema is intracellular fluid accumulation due to osmotic shift. For example, sodium potassium ATPase dysfunction. That would cause what? Increase in sodium extracellularly. When you increase sodium extracellular, you're going to draw more fluid out, and that's going to cause edema. Right? It is caused by ischemia. Ischemia because it needs an ATP. When you cannot provide that ATP, there's a dysfunction of sodium potassium ATPase. Simple thing, right? Hyperammonemia on SIADH. Okay, all of these are the causes of cytogenic edema. Again, what is cytogenic edema? Cytogenic edema basically means that you have fluid accumulation due to osmotic shift. And what is that osmotic shift? Sodium remains outside. And why would sodium remain outside? In its early ischemia, in hyperammonemia, in SIADH. Then you have the vasogenic edema. Vasogenic edema is extracellular fluid accumulation due to disruption of BBB, blood-brain barrier, that causes an increase in permeability. Increase in permeability caused by, again, ischemia, but late. High yield. Late ischemia will cause vasogenic edema. And why is that happening? Because of disruption of BBB. When you disrupt the blood-brain barrier, what's going to happen is all the excess fluid will get into the brain, causing increase in ICP. So extracellular accumulation due to disruption of the BBB, right? And that is due to ischemia. Late trauma can cause this vasogenic edema, hemorrhage, inflammation, tumors. So the whole high yield point in all of this is all about that you have with the cytogenic, you're going to think about osmotic shift, cytotoxic edema. Cytotoxic means something is there which is toxic, meaning there is a lot of sodium there, let's just say that. Okay, and then you're in the vasogenic, you're talking about something with the disruption of the blood-brain barrier, and whoever is going to disrupt this blood-brain barrier could be your late ischemia, trauma, hemorrhage, inflammation, tumor, would cause vasogenic edema. This is how it's going to look like. Let's look at the picture now. Arrows in A shows surrounding vasogenic edema. Okay, we have arrows in A. Arrows in A is showing some lesion here, and you can see, let me just erase this. So there's an edema surrounding the structure. So there's a mass occupying lesion, most likely a tumor, and that mass occupying lesion is, you will see some edema surrounding this. So this is the vasogenic edema, disruption of blood-brain barrier. Okay, and that's all for the cerebral edema. So going over the things that we just did, or ischemic stroke, right? Ischemia is infarction causing liquefactive necrosis. There are three types: thrombotic, embolic, and hypoxic. All of them can cause stroke. Treatment TPA within 3 to 4.5 hours of onset, and there is no contraindication of causing hemorrhage or risk of hemorrhage. Other than that, you can look at the other one. But what are the risk factors? Are AFib and carotid artery stenosis. Transient TIA is all about you have a reversible focal neurological deficit that occurs less than 15 minutes. For example, Aneurysms fugax, which is a transient vision loss due to retinal artery emboli coming from the carotid artery disease. Cerebral edema are due to two factors. Could be cytogenic, could be vasogenic. Cytogenic meaning osmotic shift. Vasogenic meaning disruption of blood-brain barrier. And that's all for this. Let's move on to the next. We have this effects of stroke. What are the effects of stroke? So we have the artery here, then we have the area of the lesion, symptoms, and notes. Okay, let's talk about each one of them. Anterior circulation. Anterior circulations are your anterior cerebral artery. Let's just write this down. So ACA. ACA. And then also in anterior circulation is going to be your MCA, a middle cerebral artery. And also the last one is going to be lenticulostriate arteries. Okay, which is a branch of which MCA branches off to lenticulostriate arteries to give some blood supply to the deep brain structures, which are going to be striatum and internal capsule. But let's look at the areas of lesion. Again, the areas of lesion are going to be which they supply to. Simple as that, right? Whatever they supply to, if there is a occlusion of this artery, it's going to cause lesion on that area. So what does the ACA supply to? Well, ACA supply to the motor and sensory cortices, which motor and sensory cortices of the lower limb, So if there's a lesion, you will have symptoms. Look at the symptoms here: contralateral paralysis, and sensory loss of what? Lower limb. But one feature extra that you will see here is the urinary incontinence will also be seen. Urinary incontinence. So what we will do is we'll think about a limb feature and something extra. For example, here we are looking at lower limb. With the MCA, we will look at the upper limb, but something extra, which is going to be lower face. Okay, so let's look back in what we talked about. We said lower limb and urinary incontinence will be there. And why would we have a urinary incontinence in this ACA? Because if you recall, ACA was giving supply to the frontal lobe. With the frontal lobe blood supply, when there is a lesion of this artery which supplies to the frontal lobe, is going to give urinary incontinence. Not only the urinary incontinence, but also, guess what? With the frontal lobe lesion, you will have primitive reflexes coming back. So primitive reflex will come back. That is all due to the fact that you have a frontal lobe lesion, plus behavioral personality change. But to a more extent, what you want to look for is, again, high yield point, lower limb, and urinary incontinence, and some personality change with primitive reflexes might be coming back also. But that's what the ACA. Now look at an MCA. MCA, again, supplies motor sensory to cortices, for example, to the upper limb and the face. Okay. So here, when it supplies that, so you will see paralysis, sensory loss in the lower face. Again, important is lower face there, and an upper limb. So upper limb and a lower face. Okay. When it MC also supplies the temporal lobe vernix area and the frontal lobe broca area. Okay, so area of lesion is going to be with the temporal lobe vernix area and in the frontal lobe broca area. So guess what's going to happen? Aphasia. Aphasia will happen if it's a dominant lobe. Usually the left side is dominant. Okay, but hemi-neglect if the lesion affects the non-dominant lesion or non-dominant hemisphere. So what is hemi-neglect again? So we know what is aphasia, but what is hemi-neglect? Hemi-neglect is, again, the spatial neglect we talked about. That spatial neglect. Okay. And because it's an eye problem as well, one more thing is going to be an eye problem here. That's going to be homonymous quadranopia. Homonymous quadranopia. Okay. That will be seen with this. So let's look at this. Vernix aphasia is associated with the right superior quadrant visual field defect due to temporal lobe involvement. Again, same thing what they're mentioning here. So temporal lobe, vernix area. So vernix aphasia will occur if it's associated with the right superior quadrant visual field defect due to temporal lobe involvement. If you were to involve temporal lobe, you will cause vernix aphasia, which is associated with superior quadrant visual field defect. Okay. And that will be there. Let's just go back here, calling hemi-neglect. What was we said? It's a spatial neglect, and that is calling it again, it's the unawareness of the one side of the body. One side of the whole body, they don't know on the other side. And this is the non-dominant hemisphere, usually the right side. Then we have this lenticulostriate arteries. Lenticulostriate arteries, they supply the deep structure of the brain, which is your striatum. Again, if you recall, what is striatum? If you recall neuroanatomy, striatum was what? Putamen plus caudate, right? So these two structures plus internal capsule. So you will cause lesion to all of these deep structures. The high yield point is there. If you look here, there is no sensory problem. So let's just take a look here. What do I mean by that? You have a contralateral paralysis, no sensory. But if you look top, you had a sensory things, right? Here you have no sensory, an absence of the cortical signs, which is neglect, aphasia, visual field loss. So there is going to be an absence of the cortical signs, which is going to be, for example, neglect, aphasia, and visual field loss. This is pure motor stroke, no sensories. What is it? Pure motor. Paralysis only, no sensory deficits. Common location of the lacunar infarcts, high yield. This is deep structures of the brain are common for the lacunar infarcts. Why does this happen? Well, it is due to microerythema formation and hyaline arteriosclerosis, which is also known as lipohyalinosis. Which is why did all of this happen? Well, this is due to unmanaged hypertension. Unmanaged hypertension causes what? Causes hyaline arteriosclerosis, which causes lacunar infarct, which causes pure motor stroke. That is, the lenticulostriate arteries are having this hyaline arteriosclerosis, which is in which we have a deficit. Area of the lesion are going to be deep structures of the brain, which is striatum, internal capsule, striatum meaning putamen, and the caudate nucleus. Okay, so that is all for this. So just recall the anterior circulation quickly when moving on to the next. Simple, easy, super easy, no big deal about it. Just got to know where they supply and what's going to be deficits. So ACA supplies the lower limb. You're going to have a paralysis of the lower limb plus the frontal lobe, so urinary incontinence, plus the frontal lobe deficits. MCA supplies the upper limb and the lower face. So lower face and upper limb problem. And if you want to look, you can go back and look at the homunculus and actually see where they are. And you will see that they supply the face and the upper limb, where the ACA supplies the lower limb. Simple thing. Okay. But if you have an aphasia will occur if it is a dominant left hemisphere problem. Hemi-neglect will occur if it's a non-dominant hemisphere problem. Okay. Then you have branches off to lenticulostriate arteries, which supply to the deep structure of the brain, striatum, putamen, caudate, internal capsule. It's just a pure motor stroke with no sensory problem, so only paralysis with the absence of the cortical signs, neglect, aphasia, visual field loss. Why does this happen? Because of lacunar infarct due to hyaline arteriosclerosis. That is due to unmanaged hypertension. Okay, moving on to posterior circulation. Let's change the color. Posterior circulation. Posterior circulation is a simple thing. When you talk about posterior circulation, you're going to think about posterior cerebral artery, PCA. Okay, PCA supplies the occipital lobe. So what will you cause? That's going to be contralateral heminopsia with macular sparing. Okay, with macular sparing. So let me just draw this so you know how it's going to be. So we have the macula in the center. So these guys will spare the macula. Okay, and why is this guy spared, the macula spared? Because macula is supplied by M for macula, M for MCA. It is supplied by MCA. So guess what? With the MCA stroke, you will not spare the macula. So it's a homonymous quadranopia without the sparing of this macula. Right? So here, high yield macula sparing because it is supplied by an MCA. That's why you have macula sparing. Alexia without agraphia. Again, alexia, you can't read, but without agraphia, yeah, they can't write. So they can't read without agraphia. They can't write. If it's a dominant hemisphere extended to the splenium of corpus callosum. Then you have the prosopagnosia, inability to recognize familiar faces. So simple, prosopagnosia, they can't recognize faces. If it is the non-dominant hemisphere, again, if you're looking at dominant hemisphere, you will have alexia. You will not be able to read. But just think, you cannot read and you can't read faces. One thing you can't read. Second thing, you can't read faces. If it's a dominant one, you can't read. If it's a non-dominant one, you cannot read faces. Simple. Okay. Which is, I mean, this is just a mnemonic here, but can't recognize faces. Okay. With the PCA, what else you might have? Let's just erase this. With the posterior circulation, you have the next thing, which is going to be basilar artery. This basilar artery is supplying to a lot of things. So let's look. We have the pons, the medulla, and the lower midbrain. So who's supplying to the upper midbrain? Well, that's your friend right up top. PCA is supplying. Let's just erase this. And PCA is supplying to the upper midbrain. Okay. Upper midbrain, you have with the upper midbrain, you have control of extraocular movements. For example, blinking and eye movements are normal. Again, what does midbrain do? Let me just write this here. Midbrain would give you control extraocular movements. So extraocular movements, blinking and eye movements. So blinking and eye movements. And why is this important? Now you will see when we talk about basilar artery that why am I mentioning this part up the top. Okay, blinking is normal, plus the normal eye movements are normal, right? So now if you look at basilar is supplying to the pons, the medulla, and the lower midbrain. So here, if the RAS reticular activating system is paired, the consciousness will be preserved. And if you recall, where was the RAS was? The RAS was in the midbrain. So RAS, let me just write it here. RAS was in midbrain. So because you're affecting the lower midbrain, you don't know where it is. I mean, it's either is in high in the midbrain, lower in the midbrain, it's somewhere in the midbrain, right? But if it is spared, then the consciousness is preserved. If it is not spared, you are just patient, it just goes into coma. There is no consciousness, there's no wakefulness. So RAS is the reticular activating system for the wakefulness. Okay. So let's just erase this part. So that's one point. Then it's, if you have a basilar artery lesion, you are going to cause a lock-in syndrome. Or what is a lock-in syndrome? Locked, it's basically locked in a basement. What is a lock in a basement? That if you can only look up and down and blink. So you will not be able to, this is a lock-in syndrome, meaning you will not be able to do anything. So let me just write it here. So what you can do only is you can blink and look up and down, look up and down. And why is this important? Because these functions are from the upper midbrain. Okay. And so in the lock-in syndrome, all you have, the functions that are there, is going to be that you will only be able to look up and down and blink, nothing else. Okay. Now looking at basilar artery, it's going to affect, it applies to the corticospinal and bulbar tract, which will, if there is a lesion, it will cause quadriplegia. Again, look, lock-in syndrome, quadriplegia, loss of voluntary facial, except blinking, and we mentioned why. Okay, mouth and tongue movements will also be, there's going to be loss of mouth and tongue movements. Ocular cranial nerve nuclei, paramedian pontine reticulum, so PPRF, is going to be out. It's going to cause loss of horizontal but not vertical eye movements. Again, what do we say? We say you can look up and down with the blinking and up and down eye movements, because the vertical eye movements are also gone because of PPRF, also gone, right? So with the basilar artery, what you will think about is Let's just erase all this part and think about what we were talking about. Basilar artery, lock in basement. Basilar basement. When you're locked in basement, you can't do nothing. You're locked in basement, man. You can't do nothing. All you can do is blink, look up, or look down. Okay. You're locked in basement. You're trying to look upwards. Okay. Can I go back up? Uh, uh, upstairs or not? Or you're looking down. If not up, then one day I'm just gonna go down. Okay. But blinking up and down is gonna be normal. That is the fact because the upper midbrain is supplied to PCA. Okay. And so let's just talk about the whole thing. Quadriplegia except blinking. Everything is lost except vertical eye movements, and it is known as locked-in syndrome. Locked-in basement is the mnemonic for basilar basement. Okay, and that's where we have. Then you have this basilar artery gives rise to ICA, if you recall, right? ICA is the, let's talk about each one of the things here. So we have area of lesion could be in the facial nerve nuclei, which is the CN7. CN7 nuclei will give paralysis to the face, right? Paralysis to the face, lower motor neuron lesion versus upper motor neuron lesion, the cortical strokes. With also, you will have paralysis to the face, you will have decreased lacrimation, decreased salivation, decreased taste from the anterior two-thirds of the tongue. So all of the facial nerve nuclei functions will be lost because the nuclei, the blood supply to the nuclei is out, causing paralysis of the face, lacrimation, salivation, taste out. Okay. If it was to area of the lesion is to the CN8, which is the vestibular nuclei, which is the vestibular, the spinothalamic tract, trigeminal. So let's talk about the first one, which is the vestibular nuclei, CN8. So with that, you will cause vomiting, vertigo, nystagmus. With the spinothalamic tract, you will cause decreased pain, temperature sensation, with trigeminal nucleus also being there from the contralateral body, ipsilateral face from the trigeminal, right? Sympathetic fibers, ipsilateral harness syndrome, middle inferior cerebellar peduncles will cause ipsilateral ataxia dysmetria. Inner ear will lead to ipsilateral sensorineural hearing deafness and vertigo. Okay. One of the things they might ask you, which artery is that supplies to the inner ear? That is coming from ICA. That's the labyrinthine artery. Let me write that down. Labyrinthine artery. Okay, that supplies the inner ear. That can lead to ipsilateral sensorineural deafness, vertigo also. Oh, actually, I mentioned it. Wow. Supplied by length of the artery branch of ICA. Okay, so here, the syndrome we will talk about for the ICA is, we will call it lateral pontine syndrome. So if this is lateral, which one is ventral or anterior pontine? So this is the other name for the top portion. Let me just write this down. Locked-in syndrome. The other name for the lock-in syndrome is going to be your ventral pontine syndrome. And ventral is, what is ventral is always known as anterior. Anterior part is ventral. Anterior is the same thing as ventral, right? And that's the pontine syndrome. So here we have the lateral pontine syndrome, in which the facial nerve nuclei is affected or specific to ICA lesions. So facial nerve nuclei effects are specific to ICA lesions. Okay. So a lot of things to memorize here, actually. So let's just take a look and memorize some of them, review them so you can memorize easily. So the top portion is sort of easy. Basilar, you think about locked-in syndrome with the basement. Basilar basement. You can only blink and you can only look up and down. Up meaning go upstairs, down meaning go, that's the dead end, right? ICA, on the other hand, you're looking at lateral pontine syndrome. Lateral pontine syndrome is facial nerve nuclei are affected. Could have, for For example, lower motor neuron lesion versus the upper motor neuron lesion in the cortical stroke depends upon where the location is with the facial nerve nuclei, okay, being affected. Facial nerve is so you got to know the normal stuff. So cranial nerve 7, 8, trigeminal nucleus 5 with the sympathetic fibers Horner syndrome, middle inferior cerebellar peduncles. They are going to the cerebellum, so you give you ataxia, dysmetria. Inner ear for sure, vertigo and deafness, right? And that's pretty much what we have for the ICA. Okay, now let's move on to the next, which is again some other arteries. Here we have the posterior inferior pica, posterior inferior cerebellar artery. And again, this is, we said the basilar was, let me just write this down. We said the basilar was giving rise to ICA, and ICA was then giving rise to the labyrinthine artery, right? Here, the pica and anterior spinal arteries are not from basilar artery, but they are from vertebral artery. Vertebral artery gives rise to pica and ASA, which is anterior spinal artery. So let's take a look at each one of them. So pica, area of the lesion is going to be nucleus ambiguous, which is for the cranial nerve 9 and 10. Vestibular nuclei. Again, if you think about vestibular nuclei, it's the same thing, right? It's the same thing. How? Because if you look back, it's the same thing. Vestibular nuclei is going to give you vomiting, vertigo, nystagmus. With the lateral spinothalamic tract, spinal trigeminal nucleus, the same thing from the previously. We said decrease pain, temperature, sensation from the contralateral body, ipsilateral face. Sympathetic fiber, same thing, ipsilateral Horner syndrome. Now here is just the inferior cerebellar peduncle, but the same thing because they're tackling the cerebellar disease, so ipsilateral ataxia, dysmetria. What you do not see here is the only thing, which is the inner ear. So, and what you see extra here is going to be nucleus ambiguous. Nucleus ambiguous giving rise to your dysphagia, hoarseness, and decrease in gag reflex and hiccups, right? And here, the whole syndrome would not be called the same as before, but it's called lateral medullary Wellenberg syndrome. With the lateral medullary, here's the, let me just erase my extra stuff. So you have the dysphagia, hoarseness. So nucleus ambiguous effects are specific. This guy is specific to pica. Lesions. Picture D. Let's take a look at picture D here. This is the nucleus ambiguous. Well, we wouldn't know, but it's something in nucleus ambiguous. Just think about it, okay? What we really have here is going to be your lateral medullary syndrome, in which the mnemonic is don't pick a lame horse that can't eat. Don't pick a lame horse, meaning pica. Horse means hoarseness, can't eat, dysphagia. Hoarseness, dysphagia. Okay, with increase, you can think about decreased gag, reflex, and hiccups. So the only thing extra here is going to be this. Everything gets the same. And in the last one, let's actually look at what we had similar things here. That is right here. Let's just erase this part. Take a red. Okay. The only thing extra here is going to be the facial nerve and your inner ear. So these things are going to be same. So if you remember one, you would know the other. So ICA, pica, both of them are supplying to the vestibular, spinothalamic, trigeminal, sympathetic, except here is going to be inferior cerebellar peduncle, which doesn't really matter because the symptom you're getting the same, which is ataxia, dysmetria. Okay. The only thing, if they say, okay, the facial nerve is out and they can't hear things, and that you will, facial nerve specific to ICA lesion. That you think about facial nerve, you can think about ICA. You think about dysphagia, hoarseness, nucleus accumbens out. No, my bad, nucleus ambiguous out. You will think about, for example, in your dysphagia and hoarseness, you will think about pica, which is right here. Nucleus ambiguous, dysphagia, hoarseness, pica. Okay, and that is known as lateral medullary syndrome. LM for the don't pick a lame horse that can't eat. Okay, then you have the last one, which is ASA, which is the anterior spinal artery, which is a branch of, again, a vertebral artery. Here you have corticospinal tract. Lesion area of the lesion is going to be either corticospinal tract. If that was to happen, then you will have contralateral paralysis of the upper and lower limb. Contralateral paralysis of upper and lower limb. So here, again, if you look, let me just erase this part. You have a lateral medullary syndrome, and you have a medial medullary syndrome. The mnemonic here is ants love M&M. Ants, for example, the anterior spinal artery, right? They love M&M, medial medullary syndrome. Here, well, all you have is the paralysis of upper and lower limbs. It is caused by infarcts of paramedian branches of ASA and or vertebral arteries. It also supplies the medial meniscus, which causes decreased contralateral proprioception. It also, if there is a lesion on the caudal medulla, which is hypoglossal nerve, there's going to be ipsilateral hypoglossal dysfunction. So all of these things are total extra, right? All these things. So for ASA, you will think about total 3 things extra. ASA, 3 things. Contralateral paralysis, upper lower limbs, decreased proprioception contralaterally, and ipsilateral hypoglossal dysfunction, tongue deviation. You think about tongue deviation, you think about ASA, and being mnemonic being here, the medial medullary syndrome, ants eat or ants love M&M. Okay, and that is going to be all for strokes. Okay, now let's talk about neonatal intraventricular hemorrhage. Again, simple thing with the name neonatal intraventricular. Within the ventricle, there's an hemorrhage. Now, question is why? So it is a bleeding into the ventricle. Arrows in illustration shows blood in the interventricular space. Great. There's an increased risk in premature and low birth weight infants, high yield. In neonatal infants is going to happen if it's a prematurity or there's a low birth weight baby. It originates in germinal matrix, high yield, which is a highly vascularized layer within the subventricular zone. So what is the point? Germinal matrix. It is due to reduced glial fiber support and impaired autoregulation of the blood pressure in premature infants. So you have a premature infant, you have an autoregulation problem, you cannot regulate blood pressure, which will cause the germinal matrix to bleed. Bleed where? Wherever it is present. Where is it present? Subventricular. Subventricular. When it bleeds, it's going to push that blood into the ventricle, causing intraventricular hemorrhage. Can't present. How is it going to present? High yield. Well, a neonate is going to present with altered level of consciousness, bulging fontanelle, hypotension, seizures, and coma. Okay, hypotension, seizures, and coma. Again, altered level of consciousness. So altered level of consciousness, and then you have this bulging fontanelle, hypotension, seizures, and coma. Okay, and that's going to be in the neonate. So let's just quickly review this. Premature low birth weight infant, there is no proper autoregulation of blood pressure that causes the germinal matrix, which is under this ventricle, to bleed into the ventricles because if there's a no proper autoregulation of blood pressure. So maybe high blood pressure causes this to a rupture of this germinal matrix, high yield germinal matrix. Okay, germinal matrix for the neonate intraventricular hemorrhage. It's going to present as altered mental of consciousness, bulging fontanelle, hypertension, seizures, coma. Simple. Moving on with the next one we have is the extracranial injuries. Extracranial injuries. Extracranial injuries occurs during birth, leading to blood accumulation within the scalp and skull, commonly seen in the vacuum-assisted delivery. Okay, extracranial out of the cranium. Between the scalp and between the cranium, you have some extracranial injuries. Occurs in seen in vacuum assisted delivery. For example, it's called caput secudenum. Caput secudenum, which is self-limited, again self-limited, benign, edematous swelling above periosteum, crosses the suture line, may be caused by prolonged fetal birth canal engagement. It will resolve spontaneously. Subgaleal hemorrhage, which is serious because it's a hemorrhage now, so you can think about it serious. It's a life-threatening damage to the fetal emissary veins, leads to blood accumulation between the periosteum and the gala epineurosis, presents with diffuse fluctuant scalp swelling, extending posteriorly and laterally, may lead to anemia and hypoxic shock. So because it's a lot of hemorrhage going into it, it's a very serious life-threatening damage to the veins that leads to blood accumulation. When a lot of blood accumulates, you can lead to hypovolemic shock, anemia. Where is it located? It is swelling extending posteriorly and laterally. So posterior of the head and laterally. Okay. And that's the subgaleal. What is the subgaleal? These are the veins. Which veins? Emissary veins. Between the which blood will accumulate between the let me erase it. I think I messed up a lot. Blood will accumulate between the periosteum and the gala epineurosis. Veins are damaged. Okay. Then you have the cephalohematoma. Cephalohematoma is just the blood accumulation between the skull and the periosteum. Does not cross suture line. May be caused by forceps delivery. A patient with a forceps delivery can lead to cephalohematoma. It will present as firm, localized. Let's see the difference. This is firm and this is fluctuant. Localized swelling over the periosteum or occipital lobe may lead to indirect hyperbilirubinemia because all that blood will get destroyed, leading to increase in bilirubin levels. Okay. And that's what we have. So again, let's just recall the whole thing and move on to the next simple thing. Caput secudenum. This is self-limiting. It happens prolonged fetal birth within the canal engagement. So the fetus stays in the birth canal for a longer period of time, causes this caput secudenum. Subgaleal hemorrhage is all about emissary veins being damage to them, causing blood. It will accumulate enough to cause a fluctuant scalp with anemia and hypovolemic shock. Cephalohematoma is just a blood accumulation, which will present as firm, localized swelling in the forceps delivery. It can increase the indirect bilirubin. That's all for this. Okay, now let's talk about intracranial hemorrhage. Now we did talk about extracranial. Now it's the intracranial hemorrhage. So intracranial hemorrhage, first of all, we have this epidural hematoma above dura. So if you just recall the normal anatomy, you have the pad, right? So you have a brain parenchyma, which is the brain. Attached to the brain is the pia mater, then you have the arachnoid, and above the arachnoid you have the dura mater, which is the mnemonic pad, right? And then you just have on top, you have this skull, right? So here what we have is epidural, meaning it's going to be hemorrhage here in the epidural space. So rupture and high yield is, why do you have epidural hematoma? Epidural hematoma is due to the fact that there is a rupture of middle meningeal artery, which is a branch of maxillary artery. Maxillary artery is a branch of external carotid artery. So external carotid gives rise to maxillary rise to MMA, middle meningeal artery. High yield is meningeal artery and maxillary artery, often secondary to skull fractures. with a circle in A. Let's take a look at that. So here's the picture. If you'll take a look, you have a fracture of the bone here, and that causes epidural hematoma involving the pterion. Pterion, what is a pterion? It's the thinnest part of the lateral skull. Pterion is basically where all the bones on the lateral side, they join together. And it is the thinnest part of the lateral skull. So which is the thinnest part, it is most likely to get injured if there's a trauma, right? It is most likely to get injured if there is a trauma, okay? Might present with transient loss of consciousness, which, so a patient would undergo transient loss of consciousness, and then there is a recovery that is called lucid interval. With the lucid interval, there is a rapid deterioration due to hematoma expansion. That hematoma would expand, and there's going to be rapid deterioration after the recovery. Okay. So again, this is our yield point. That is, patient gets the epidural hematoma, let's say due to trauma or anything. The patient undergoes transient loss of consciousness, at the time of the impact. So you get a trauma, you're going to get loss of consciousness, but rapidly there's a recovery, which is known as lucid interval. So what is the lucid interval? Patient regains consciousness, okay? And when the patient regains consciousness, the patient, hey, I'm fine, I'm doing great. But that's actually not what's really happening to him or to her. So there's a rapid, when the patient regains consciousness, there's a rapid deterioration due to that hematoma, that bleeding that was in the epidural space that would expand, and that will lead to rapid deterioration in the condition of the patient, leading to again loss of consciousness. But here, this loss of consciousness would not be transient. Okay, so that's why it's very important for a trauma patient that goes into LOC, loss of consciousness. That's a really high yield point that they can or go into lucid interval. Okay, the next thing we have here is scalp hematoma, iris in A. Again, we looked at that scalp hematoma. Let me erase this part. Scalp hematoma. And rapid intracranial expansion, which is B. Let's take a look at rapid. There's going to be rapid intracranial expansion of that hematoma under systemic arterial pressure, which causes transtentorial herniation, high yield. It will lead to transtentorial herniation, and that's going to give cranial nerve 3 palsy, CN3 palsy. And with the so for example, transtentorial uncal herniation, and that's going to cause CN3 palsy. With the CN3 palsy, again, you will think about what and why did first of all, because of this transtentorial herniation, you get CN3 palsy. But why did you get this transtentorial herniation? Because of increased under systemic arterial pressure, you're increasing, let me just write this down here, you're increasing intracranial pressure so much that it's going to cause herniation of the transtentorial herniation, and also that increased ICP will cause coma and death can happen. Plus, you will see sign and symptoms of increase in ICP. Again, all of these are due to the fact you're increasing the ICP. Again, scalp hematoma would lead to rapid ICP increase. Intracranial expansion will occur, that will lead to increased ICP, and that will lead to transtentorial herniation, which will cause CN3 palsy. But due to increased ICP, you will see sign and symptoms of increase in ICP, and you will also can cause coma and death to the patient due to increased expansion of hematoma, increasing ICP. All right. Now, high yield is CD would show what? CD would show biconvex, a lentiform, which is simply saying lens shaped, hyperdense blood collection. Again, hyperdense is the white. So let's just take a look what we talked about. Blood will look like white. What do you see here? White, right? So hyperdense blood collection, which is not crossing suture lines. And why is it not crossing suture lines? Because dura is attached. So dura is attached to the suture lines and dura is intact. So let's just so we said here the dura, so there are suture lines here, and dura is intact to one to another suture lines. And because it is intact, the only blood is going to, let's just change color, the blood is going to accumulate here within that suture line, giving you a lens shaped biconvex lesion, because it is attached, dura is attached to the suture lines, high yield. And we'll talk about if it is not attached, what's going to happen. On top of that, you will also see that here, so just remove this, you also see midline shift. If you look at the midline shift, there's a sort of a midline shift here due to that rapid expansion of that hemorrhage. So there you will see midline shift, which is enlarging hematoma, compresses and shifts the midline, right? Enlargement hematoma pushes on to the brain, and that causes shifting of the midline structures or midline shift. Okay, so let's just recall this whole thing and move on to the next thing. So here we talked about how we have, let's just get this, epidural is above the dura, so suture lines will not be crossed because dura is attached to sutures and it is intact. Okay, and why does hematoma happen? Because of MMA. MMAs are what? What do you think about when we say MMA? You think about fighting, right? You think about trauma. So here's the secondary fracture trauma leading to MMA being the middle meningeal artery rupture. Okay, in here. What is the thinnest part? The pterion, right? That leads to transient loss of consciousness, recovery, lucid interval, but rapid deterioration. Scalp hematoma, which increases the ICP, will lead to transtentorial herniation, CN3 palsy, but also increased signs and symptoms of ICP increased. And CD will show high yield because it's going to be, sutures are intact. So here's the sutures. Oh, what's going on? Here are the sutures. Here's the dura. Dura is a type 2 suture, so you will see lens-shaped, lentiform, biconvex, a lesion on the CT scan, hyperdense, meaning white blood will be seen. And that is all. Plus, on top of that, you will see midline shift. Moving on with the second one, which is subdural hematoma. Again, it is subdura, as the name suggests, so it's under the dura. When it is under the dura, guess what? There are no suture lines, right? So let's look at that. So here, subdural hematoma is due to the fact that there is going to be rupture of the bridging veins. Again, comparison. Top one was artery. Here's the veins. So can be acute due to traumatic, high energy impact, which leads to brighter or hyperdense CT. Again, blood looks brighter, hyperdense. Or chronic associated with mild trauma, in which case you will have cerebral atrophy, increase in age, or chronic alcohol overuse leads to darker, hypodense CT. So again, if you look here, what are they trying to say? They are saying simply that you have first of all, you have a rupture of the bridging veins, but could be due to acute thing or could be due to chronic stuff. So acute thing is going to be due to the fact that you have a traumatic impact. Okay, that causes hyperdense lesion on the CT. Or chronically, meaning it's not going to happen acutely, meaning gradually it's going to happen, and which could be associated with, if you don't look at trauma, if you look at here, cerebral atrophy. Chronically, it can happen if you have a cerebral atrophy, increase in age, chronic alcohol overuse, which will look at like darker hypodense on the CT scan. So the acute, now let's just present one more thing. The acute will present as coma at onset, coma at the onset. So a person gets a traumatic injury, he goes into coma, loss of consciousness, coma. Okay. Well, chronically, these patients will present as gradual onset of headache and confusion, headache plus confusion, gradual onset, and they have either increased age, which causes cerebral atrophy, or their chronic alcohol overuse. Now, if you give them a little mild trauma, a little bit of trauma, that's not actually a trauma, but it's a mild trauma, they will mess up their bridging veins. As you know that, okay, here are the bridging veins coming, the bridging veins, and as you cause cerebral atrophy, these bridging veins get the tension. So with a mild trauma, they can break. With a mild trauma, they can break. When they break, and in cerebral atrophy, when does it happen? When increase in age. Okay, so with mild trauma, they can break, causing hematoma formation. Okay, that's the chronic one. Also seen in shaken baby, same thing here. Shaken baby syndromes, right? With a shaken baby syndrome, you have again the bridging veins. They can rupture. Okay, and causing causing hematoma formation. This is going to look like a crescent-shaped hemorrhage. Let's look at in the picture. A crescent without a suture line, so it crosses the suture line. So because it's under the dura, so it crosses suture lines. It's a crescent shape. Just look at the picture D and C. Okay, here. Picture C and D, crescent shape. It's crossing suture lines and can cause midline shift. Again, it can also cause midline shift. Findings of acute or hyperdense borders or chronic hypodense. Hyperdense is white. White is blood with a border, white border, and hypodense hemorrhage, which is blue. Let's take a look at that. Here you have hypodense, black, and look at the borders, hypodense, and with the white here, hyperdense area. So you know this is acute and this is chronic. Okay, but important point is crescent shape. There's a crescent shape. Okay, so let's just recall this thing. So subdural hematoma, we said it is due to the bridging veins. Let's just remove quite a bit part here. Recall. So we said it is due to the bridging veins. Again, brains have they are low pressure, so they will bleed slow. Slow bleeding will occur. Okay, and with this you can have an acute traumatic, or you could have chronic due to cerebral atrophy. And cerebral atrophy increases the space between what? Increases the space that the veins must cross, right? For example, as I mentioned, you have cerebral veins, and here's the cerebral atrophy occurred. So from normal, now it's, let's just say the veins have to cross more area because there is a cerebral atrophy. So now they are in high tension. Any tension occurs here, they will break, and that is seen with increase in age. Okay. So classic history with the chronic one, you will see that confusion, that's going to be presenting with episodes, gradual onsets of headaches and confusion. So headaches and confusion will be seen. Other than that, what else might be there? Let's take a look at this acute subdural hematoma. Acute is going to be hyperdense lesion, meaning white, and chronic will give you hypodense lesion. But if you look at this picture D, you have a hypodense lesion, but here you also have hyperdense lesion. Okay, so that is also seen. And yeah, that's pretty much what we have for subdural hemorrhage. Then we have this subarachnoid hemorrhage. Subarachnoid hemorrhage is under the arachnoid. So again, you had a pad, PAD, right? So under arachnoid is going to be subarachnoid. So it is bleeding due to trauma, rupture of the aneurysm, such as saccular aneurysm, saccular high yield, that there's a rupture of the saccular aneurysm, uh, or AV malformations. Okay. Also, you have some, you can think about some risk factors could be rupture of aneurysms, and also your autosomal dominant polycystic kidney diseases, ADPKD, for example, and connective tissue disorders, for example, Marfan's. So think about all of them where you have a trauma or rupture of the aneurysm, saccular aneurysms. Okay. So what's going to happen here is that there's a rapid time course, meaning the patient will complain of worst headache, high yield, worst headache of the life. Patient will complain, let me erase this part. Patient will complain of worst headache of my life. You will have bloody or yellow xanthochromic lumbar puncture. So bloody or yellow LP. High yield vasospasm. Vasospasm can occur due to blood breakdown or rebleed 3 to 10 days after hemorrhage that causes ischemic infarct. Nimodipine, it is used to prevent the it is used to either prevent or reduce vasospasm. Okay, increased risk of developing communicating and non-communicating hydrocephalus. Again, what is going to be here? First of all, you have the sudden onset of worst headache of my life, high yield. You do an LP puncture, lumbar puncture. You will see xanthochromic, which is bloody or yellow fluid on the LP. On top of that, you have, because it's going to cause, because it is here, what you have is sudden onset worst headache of my life. Because of that, you will also have irritation of the meninges causing knuckle rigidity, plus photophobia and fever. Okay. On top of that, there is going to be high yield point is that there is no focal deficits and loss of consciousness in about 50% of the individuals. Okay. Let's just erase all this. Let me again write down what I'm trying to say. Worst headache of my life with knuckle rigidity, with fever. You think about, hey, maybe meningitis, right? So you look for LP, you see blood or yellows and the chromium LP. Okay. And that's how you would right away tell, okay, it's the bleed at the bottom of the brain. That's the subarachnoid. Again, pad under the arachnoid. There's a bleed. Now, high yield point is vasospasm. Now, the vasospasm is when this bleed is going to break down, the blood, whatever, this blood will break down, right? Or if it was to rebleed within 3 to 10 days after the hemorrhage, it's going to cause ischemic infarct. It's going to cause ischemic infarct. Okay, here what we're going to have this thing, vasospasm. So first thing, vasospasm, we know this arterial, we're talking about arterial vasospasm, will occur due to blood breakdown, one thing. That is one thing. Blood breakdowns causes the release of breakdown material, which causes arterial vasospasm, one thing, right? Second thing is the damaged endothelium will not be able to release nitric oxide, which is normally vasodilating. So you will not be able to release nitric oxide, and that leads to all of this will cause release of vasoconstrictive factors. Okay, and that vasoconstrictive factors would lead to ischemic infarct. That's one thing. Or in other case scenario, there is actual rebleeding within 3 to 10 days after the hemorrhage. So you already have a hemorrhage there. But again, as soon as you open the vessels, there's a rebleeding. And that leads to ischemic infarct. Now, high yield point is that ischemic infarct, how is gonna show? Well, so rebleeding after the initial subarachnoid hemorrhage occurs usually less than 24 hours after the initial bleed. So rebleeding will occur rebleeding after the initial SAT occurs usually less than 24 hours after the initial bleed and will show sudden change in the mental status. So when the patient, when he goes home, anything is fine, you look at the CT, everything was fine, but the repeated CT comes back, the patient comes back with a new focal neurological deficits, and then you do the CT scan again, and you will see the problem there again. And that is due to the fact that either you have blood breakdown or decrease NO, or you have a rebleeding in the hemorrhage causing ischemic infarct. To prevent this, how do we prevent this now? To prevent this, we can give nimodipine. Now, nimodipine is used to prevent or reduce that vasospasm. Nimodipine is a calcium channel blocker, CCB, that will not let this vasospasm to happen. So what's going to do, so what's happening is there was a vasospasm, right? And when you give the calcium channel blocker, you will not go into the narrowing of the vessel, and they will remain vasodilated, no matter you are giving them breakdown products of the blood or you're not giving them nitric oxide. You will not go into vasospasm. When you do not go into vasospasm, you're not going to go into ischemic reinfarct or ischemic infarct later on. So nimodipine is a very important drug that we can use in the subarachnoid hemorrhage. I hope that makes sense. Now, there's again with this increase in subarachnoid hemorrhage, there is increased risk of developing communicating and non-communicating hydrocephalus. Okay, with the hydrocephalus can occur hours and days after due to the blood breakdown, obstructing the CSF flow, leading to patient develop signs and symptoms of increase in ICP again because of hydrocephalus, increase in intracranial pressure. Okay, and CT would show ventricular dilation if hydrocephalus was to develop. The treatment could be for this thing, could be mannitol. Treatment is mannitol for the hydrocephalus to decrease that blood pressure. And that is all we have. Okay, let's just review this and move on to the next. We said subarachnoid. It is under the arachnoid. It is bleeding due to trauma, or the high important thing is rupture of aneurysm. Aneurysm, secular aneurysm. Secular aneurysm is also associated with ADPKD, which is autosomal dominant polycystic kidney disease, or connected to disorders like Marfan or AV malformations. It is it occurs rapidly. Patient will say, it is the worst headache of my life. On top of that, it will also have a knuckle rigidity, which is stiffness of the neck, pain, neck stiffness, with photophobia, with fever. You think about, okay, meningitis sort of a thing. You look at LP, it's a bloody yellow lumbar puncture. Okay. And that is all due to the fact that you had a vasospasm can occur due to that bleeding would break down, causing vasospasm, and that is also due to the fact that you could not release nitric oxide to cause vasodilation of the vessels, or there's a rebleeding after the hemorrhage that would eventually all of them could cause ischemic infarct. So that will look when the patient comes back with the neurological deficits. You look at CT, you will see that. Nimodipine, high yield. Now, the mnemonic for nimodipine is, if you think about there's one movie, the fish Finding Nemo. So where did the fish go? Fish goes in water, right? Where are fish? Fish are in water. So here in the hemorrhage, you can think about that Nemo again. So blood is like water. Fish will float in water. So float in the blood hemorrhage. So Nemo is given high yield to prevent or reduce that vasospasm, and there is increased risk of communicating non-communicating hydrocephalus. Hydrocephalus will lead to increase in intracranial pressure, and that's going to lead to signs and symptoms. The treatment would be mannitol to decrease that hydrocephalus, to decrease that increase in ICP. And that's pretty much what we have for this one. Moving on with the next one is called the intraparenchymal hemorrhage. Intraparenchymal is the most commonly caused by systemic hypertension now. Also seen with amyloid angiopathy, which is recurrent lobar hemorrhagic stroke in older adults, NAV malformations, vasculitis, neoplasm. Okay, so you think about anything that would it is commonly high yield as this systemic hypertension, amyloid, and then think about anything else that can lead to intracranial hemorrhage, intraparenchymal hemorrhage. Vasculitis could be there, neoplasm could be there, maybe due to secondary reperfusion injury in ischemic stroke. Now here what you have is hypertensive hemorrhage, hypertension that caused hemorrhage, which is known as high yield Charcot-Bouchard microaneurysm. Again, hypertension, hemorrhage, Charcot-Bouchard microaneurysm most often occurs in the putamen globus pallidus of the basal ganglia. Again, think about basal ganglia. Basal ganglia is what? Is the deeper structure of the brain. So it is supplied by lentricostriate arteries. So didn't we talk about this in the MCA stroke? We said there was as uncontrolled hypertension, which causes arteriosclerosis, and that is in the lentricostriate vessel, followed by internal capsule, thalamus, pons, and cerebellum, all of them. So think about it this way. You have putamen, globus pallidus of the basal ganglia. So we have basal ganglia. These are all deep structure of the brain. Internal capsule, thalamus, pons, cerebellum. Okay, so this is all for this one. Let's take a look at picture G and H. We have a G and H. Okay, here's the deep structure of the brain. In the deep brain, lentricostriate arteries are supplying this deep brain, and hemorrhage there is going to happen with an H, cerebellum, deep structure. Okay, so let's just review this part. Intraparenchymal hemorrhage within the parenchyma of the brain. There's a hemorrhage due to systemic hypertension, due to amyloid, due to AV malformation, vasculitis, and neoplasm, may be secondary to reperfusion injury. But what is important is there is an hypertensive hemorrhage, which is known as Charcot-Bouchard microaneurysms, which occurs in the putamen and GB of basal ganglia, which is lentricostriate vessels, followed by internal capsule, thalamus, and pons, cerebellum, all deep structures of the brain. Uncontrolled hypertension causes Charcot-Bouchard microaneurysms. And that is all for this one. Okay, now we have thalamic pain syndrome. Thalamic pain syndrome is a neuropathic severe pain, which is a treatment-resistant neuropathic pain following thalamic lesion. I think we did talk about if we have a thalamic lesion, we can fix everything, but the pain will not be able. We will not be able to fix the pain, and there is going to be a pain after the thalamic injury, even if we fix the problem, even if we fix the thalamus, right? Still, there's going to be pain known as thalamic pain syndrome. It is why did it happen? Because of occlusion of the lentricostriate artery. Again, lentricostriate artery is, going to the deep structure of the brain, supplying thalamus and all. Initial paresthesia followed in weeks to months by allodynia, which is ordinary painless stimuli can cause pain. So again, what is this? Ordinarily painless stimuli can cause the pain. So like touching wouldn't cause you pain, right? But you have allodynia or something, which is basically a pain with a very small stimulus, or hyperalgesia, which is hypersensitivity to pain. Dysesthesia, which is altered sensation on the contralateral side. So all we have here is a simple thing. It's just the names, nothing else. Thalamic pain syndrome. It is a treatment-resistant pain after thalamic lesion, and due to occlusion of the lentricostriate arteries. Okay. Then you have this phantom limb pain. It is sensation of burning, aching, electric shock-like pain in a limb that is no longer present. Wow. Limb is out. You have a phantom limb pain. You still have the burning, aching, electric shock-like pain when the limb is not even there. Common, if of course, when the limb is not there, that's the amputation. Common after amputation, associated with reorganization of the primary somatosensory cortex. Why this happening? Because of reorganization of the primary somatosensory cortex. But just remember the name phantom pain. Phantom is I guess a Rolls Royce car. Just think about, there's an accident. Phantom, Rolls Royce, Phantom. You were going on a road, there's an accident, someone lost a limb, there's an amputation. But the Phantom, the person is not going to forget that car, right? So there's a Rolls Royce Phantom limb pain after amputation. All right, the next one we here have is the diffuse axonal injury. We did touch a little bit in the neuroanatomy, but here we have is a traumatic shearing of white matter tracts during the rapid acceleration, deceleration of the brain. For example, motor vehicle accident is MVA. So in MVA, you have a rapid acceleration and deceleration of the brain. It usually results in devastating neurological injury, often causing coma, persistent vegetative state. MRI shows multiple lesions, multiple punctate hemorrhages. Look at it here, multiple punctate hemorrhages involving white matter tracts. So it would involve the white matter tracts. So as the name suggests, diffuse, meaning multiple, axons, injury, white matter. Axons is in the white matter. Injury means injury. Injury is where? MVA, simple, right? Diffuse, again, it's going to be multiple. Axons, white matter. Injury, MVA, okay? And it's going to cause what? Coma or vegetative state. Then we have a very important one here is the aphasia. What is aphasia? Aphasia is the higher order language deficit. Inability to understand, produce, use language appropriately caused by pathology in the dominant cerebral hemisphere, usually the left side. Aphasia is the dominant cerebral hemisphere. Distinguished from dysarthria, which is motor inability to produce speech. Again, dysarthria, it's a motor inability to produce speech, movement deficits. And we did touch this on neuroanatomy, but here again, let's just go over these again. Here what we have is, we have the Broca. Aphasias are types, right? The Broca, which is expressive aphasia, Wernicke's receptive aphasia, conductive aphasia, and global aphasia. So the Broca area is inferior high yield is this point. The area of the Broca, area of the Broca is an inferior frontal gyrus of the frontal lobe, while the area of the Wernicke's is in superior temporal gyrus. So if you look at again, inferior frontal gyrus, superior temporal gyrus. Okay, high yield. And these both areas are supplied by what we did talk about at MCA. MCA supplies both areas, the frontal and the superior temporal gyrus, both of them, which are the Broca and the Wernicke's area. Okay. And here with the Broca areas, as you know, the mnemonic broken mouth, which is right there, broken boca, mouth. It's going to be non-fluent speech. Because you have a broken mouth, how can you have a fluent speech? It's just, it's common sense. You have a broken mouth, you can't have a fluent speech. But intact language comprehension, they know what to say, but they can't say because they have a broken mouth. Okay. Patient appears frustrated. They're like, I want to say this, but I can't. What do I do? Restoration is going to be there. Insight is intact. Okay, which is again, comprehension is basically intact. And what is comprehension again? Comprehension is understanding written and verbal language. So they understand if you write them something, written, verbal language, they understand every single bit of it, but they will not be able to speak. Broken mouth, Broca area. Moving on with the Wernicke's, which is receptive. Wernicke's area is in superior temporal gyrus, high yield of the temporal lobe. They have a fluent speech with impaired language comprehension. Okay, so they have Wernicke's area is the word salad. Whatever they're saying, it doesn't make sense. Whatever they're saying, they're just saying a lot of things, but nothing are comprehended. You can't understand them. Okay, so comprehension is impaired. They don't have an insight. Comprehension is impaired. Then you have the conduction. Now, conduction is all about your arcuate fasciculus, which is connecting, if you look here, arcuate fasciculus is connecting the bocca and the vernix. If you mess this up, if you get the damage to this arcuate fasciculus, you will have impaired speech repetition. Impaired speech repetition. With a global, you have global meaning both areas are affected. The broca is down, vernix is down, both are affected. What you're gonna get is non-fluent speech, broken mouth, and with the broken not fluent speech with impaired language comprehension, they will not be able to comprehend, which was due to the fact that you have just affected the broca and the vernix area. Both of them are affected. Okay, so that is all. So let's just quickly review this and move on to the next. We get the broca, broken mouth, good mnemonic. High yield is inferior frontal gyrus. So the broca is in inferior frontal, whereas vernix is in superior temporal gyrus. Vernix is for word salad. Broken mouth, they're not fluent in speech, but comprehension is good. Vernix is word salad. They have impaired language, and they do speak, but their comprehension is not there. Conduction problem, meaning you don't have a conduction. Simple means conduction, one point to another point, conduction. Meaning arcuate fasciculus is out. Impaired speech repetition. Global meaning both are out. Broca and vernix both are affected. You will have a non-fluent speech with impaired language comprehension. And that is all for aphasia. Okay, now let's talk about aneurysm. In aneurysms, what do we have? Is the abnormal dilatation of an artery due to weakening of the vessel wall. So we have the first thing we have is saccular aneurysm. Saccular is also known as very high yield. We all know about it. It's called Barry aneurysm. Saccular aneurysm, Barry aneurysm, right? Barry aneurysm. It occurs at the bifurcation of the circle of Willis. Bifurcation of the circle of Willis. Most common site is junction of the ACOM and ACA. Let's take a look at ACOM and ACA. This is ACOM and this is ACA. At the junction of that anterior cerebral artery and ACOM, there is that's the most common site for this Barry aneurysm. Okay, it is associated with what we talked about just at the hemorrhages. We talked about it. They are all these saccular aneurysm, which are also known as Barry aneurysm. They're all associated with ADPKD, which is autosomal dominant polykidney disease. Connective tissue disorders, which are Ehlers-Danlos syndrome, Marfan syndrome, right? Other risk factors are increase in age, hypertension, tobacco smoking. They're usually clinically silent unless rupture. So these aneurysms could be there, right? But unless and until they rupture, which is the complication, can lead to, again, subarachnoid hemorrhage, which is, again, the same thing here. Worst headache of my life, or thunderclap headache, which leads to focal neurological deficits, can cause symptoms via direct compression of the surrounding structures by growing aneurysm. So aneurysm was to grow, it's going to compress some structures nearby that can cause a problem. That's one thing. The other thing, most common complication, is when they rupture, they lead to subarachnoid hemorrhage, which is the worst headache of my life with thunderclap or the thunderclap headache. Okay, now here are the arteries. So ACOM, if there is a ACOM compression, which leads to, if you were to compress this ACOM due to this aneurysm, it can lead to bitemporal heminopia, which is it leads to compression of the optic chiasm. And this is we will see in ophthalmology is a pretty nice picture there. Visual acuity deficits are also seen. If this aneurysm was to rupture, it's going to cause ischemia in the ACA distribution. Again, ACA was where it was all about your lower extremity and your urinary problem and semi problem, which was a contralateral lower. So I don't know what it was. You can go back and take a look, But here, all we have the high yield. Actually, there wasn't anything with the eye, but it was all about frontal lobe. Frontal lobe, lower extremity, and urinary problem. Three things with the ACA distribution. Again, here, contralateral lower extremity hemiparesis, sensory deficits also there. With the ACA rupture, MCA rupture, if you look, let's take a look at the picture. MCA. Here's the MCA. MCA getting that aneurysm formation. And if there is an MCA rupture, it's going to cause ischemia in MCA distribution. Again, MCA was all about your upper extremity and lower face. Upper extremity, lower face. So here, upper extremity, lower face, hemiparesis, and sensory deficit. Again, PCOM, which is the posterior communicating artery compression due to this aneurysm, can lead to ipsilateral cranial nerve 3 palsy. PCOM, look at this PCOM. This is your aneurysm. It can lead to mydriasis, and which is a blown pupil, may also see ptosis, down and out eye. With the CN3 palsy, you all know it's a down and out pupil with blown pupil, meaning dilated pupil, is the mydriasis with the CN3 palsy. Okay, so this is all about your secular aneurysm. Let's take a look at this picture, circle of Willis. Very nice, beautiful circle of Willis. We have the first one. We have this anterior communicating artery aneurysm. We can see that. Secondly, we can have an MCA aneurysm. We do see that right here. On the third, we have the basilar tip aneurysm. And this is the basilar artery. At the tip of it, we can have an aneurysm. And the fourth thing is the PCOM aneurysm. And we talk about each one of them, how they are. But again, the deficits are the same thing that we talk about in strokes, because that's the area of the supply, right? Except that we didn't talk about much. So here with the ACOM, you can think about the extra stuff. Or actually, we did talk about ACOM and everything else as well. But PCOM is going to give you CN3 palsy. Okay, so that is going to be there with these things. Now we have the next part, which is going to be Charcot-Bouchard microaneurysm. We did touch on it. Let's talk about the whole thing. It is associated with chronic hypertension. Chronic hypertension affects the small vessels. Again, those small vessels which supply the deep brain or lenticular arteries in the basal ganglia, the thalamus, can cause hemorrhage in the intraparenchymal strokes. Right? Hemorrhagic intraparenchymal stroke. Not visible on angiography, because they're very small vessels. On angiography, nothing is seen. Okay, all you see is you have a chronic hypertension, which causes arteriolosclerosis of the small arteries, which known as Charcot-Bouchard aneurysms, in which Charcot-Bouchard aneurysm, which arteries are we talking about? We are talking about specifically lenticular arteries. Where do these supply? These supply the deep brain structure, basal ganglia, the first thing, then the thalamus and the rest. Okay, and they cause hemorrhagic intraparenchymal stroke. So you see how everything we talked about, how many times this book is repeating itself over and over and over again, so that you grasp the really good concepts of it. That's the beauty of this book. Okay. Now let's talk about the fever versus heat stroke. With a fever and a heat stroke, it's a simple thing. All you have to just think about is the temperature. With a fever, you're not going to have any temperature more than 104. But with the heat stroke, you are going to have a temperature greater than 104. Most likely with a fever, you're going to have less than 104. But with heat stroke, you for sure you're going to have greater than 104. Okay. With this, let's talk about the pathophysiology. In fever, who's causing this fever? Well, it's the cytokines activation during the inflammation. But in the heat stroke, who's causing all of this fever or increase in temperature? Because you are not able to dissipate the heat exertion. You can't dissipate the heat out of the body, causing an increase in temperature of the body, causing more than 104. So this is sort of a physiological pathological, but within the normal physiological actions. But here you're just looking at pathology. The body is like, what's going on with me? Well, the complication is going to be febrile seizure. They are going to go into seizure, which is known as febrile seizures, which is benign, self-limiting. With a heat stroke, it's a CNS dysfunction, for example, confusion. The muscles will break down, leading to rhabdomyolysis. And that rhabdomyolysis can cause acute kidney injury, ARDS, and DICs will start happening. Acute respiratory distress syndrome, disseminated intravascular coagulation, okay, DIC. On top of that, how do you manage this? Well, the fever is simple. You give acetaminophen, ibuprofen for comfort does not prevent future, important, it would not prevent the future febrile seizures. Simple thing. Why would it, right? Antibiotic therapy if indicated. The other guy, heat stroke is just about rapid external cooling, rehydration, electrolyte correction. External cooling is the way out for this guy. External cooling with rehydration and electrolyte correction. All right, let's review this. We talked about aneurysms. The aneurysm is just an abnormal dilatation of the artery due to weakening of the vessel wall. And weakening of the vessel wall, for example, saccular aneurysm, which is also known as Berry aneurysm. The weakening of the vessel wall occurs at the bifurcation of the circle of Willis. Most common site is ACA and ACOM, junction of the AC and ACOM, okay? And it is associated with ADPKD and Ehlers loss, Marfan syndrome, connective tissue disorders, which also, it's also one of the risk factors for all connective tissue disorders, aortic coarctation or coarctation of aorta. Okay, other risk factors for saccular aneurysms are advanced age, hypertension, tobacco smoking. But the important point is that these aneurysms are clinically silent. You will not see a thing unless they rupture, which can lead to complication. The most common complication is your subarachnoid hemorrhage. And again, subarachnoid hemorrhage is the worst setting of my life with fever, with knuckle rigidity, which is neck stiffness basically. Okay, and which also leads to focal neurological deficits. Can cause symptoms-wide direct compression of the surrounding structures in growing aneurysms. For example, if this aneurysm was to grow enough to cause the compression of the ACOM, will lead to bitemporal heminopsia. Bitemporal heminopsia meaning simple thing, you have on the temporal sides, you will not be able to see. So bitemporal heminopsia, okay, because of the compression of the optic chiasm, which is a visual field defect. Rupture causes ischemia in the AC distribution, which causes lower extremity hemiparesis and sensory deficit. With MCA, you're going to cause upper extremity and facial problem. With PCA, you will cause, not PCA, but PCOM, you will cause ipsilateral CN3 palsy. Ipsilateral CN3 palsy. And then you have this Charcot-Bouchard microaneurysm, was again due to hypertension, causing this deep structure problem through the lenticostrid arteries. Fever and heat stroke. Fever means fever would not be greater than 104. If you see greater than 104, think about heat stroke, because body cannot dissipate the heat, cannot take out the heat, okay? And so the only way you want to take out the heat is through external cooling, rehydration, electrolyte correction. With a fever, acetaminophen, but it will not prevent the future febrile seizures. And why would it? Simple thing, right? And that is all for this topic.